You know, it's easy to think of healthcare as just, well, your doctor's visits or maybe that confusing insurance bill you get sometimes.
Hmm.
But underneath all that, there's this incredibly complex system. It's like a web, really, of rules and organizations, and it touches every single one of us.
Yeah, absolutely. Whether you're actually working in healthcare or just, trying to navigate it as a patient.
Exactly. And getting a handle on it can feel, well, pretty overwhelming. So today, let's try and cut through some of that complexity.
Definitely. For this deep dive, we've pulled together quite a few sources. We've got official healthcare regulations, documents, details on how organizations get accreditation,
Yeah,
that sort of thing.
right.
And our mission, really, is to give you a clearer, more um, understandable look at this world of healthcare regulation and accreditation. It can be pretty opaque sometimes. We want to highlight what's really important.
Think of this as maybe your shortcut to understanding the engine room of healthcare, and
Mhm.
more importantly, why it actually impacts you directly.
Hmm.
We're going to try and uncover some surprising connections, maybe some crucial details that often just get lost in all the jargon.
Yeah, because at the end of the day, this isn't just about policies and procedures, is it?
Not at all. It's about making sure you get the best possible care, knowing your rights as a patient, and understanding the forces that are shaping the healthcare you actually receive.
Okay.
Okay, so let's dive in. Let's maybe start with accreditation, this idea of voluntary quality assurance.
Accreditation is a really interesting place to start, actually. It basically represents a healthcare organization's choice to go through this rigorous evaluation.
The choice.
Yes, by independent, non-governmental bodies. These organizations, they aren't part of the government. Their whole focus is just ensuring high standards.
Ah, okay. So it's like a hospital or clinic raising its hand and saying, hey, check us out, tell us if we're doing things right, instead of just waiting for the government to mandate something.
That's a great way to think about it. Accreditation looks at the big picture, you know, the organization's performance, how they prioritize patient safety, the actual quality of care, how efficient they are.
Okay.
The organization does a self-assessment first, and then these external experts, peers really, come in to see if they're meeting these established benchmarks. But it's crucial to remember this is about the system, the organization as a whole.
Right, not judging individual doctors or nurses necessarily.
Exactly. It's about how the organization functions.
Okay, so who are the main players here? Who are these independent organizations doing the accrediting?
Well, the big names you'll probably hear most often are the Joint Commission. They accredit a really wide range of organizations.
Mm-hmm.
Then there's the National Committee for Quality Assurance, or NCQA. They're very well known for their work with managed care plans, health plans,
Okay.
and also the Accreditation Association for Ambulatory Healthcare, AAAHC. As the name suggests, they focus more on outpatient settings, clinics, surgery centers, that kind of thing.
Right, so different bodies for different parts of the system, and these are the groups setting that quality bar, but only for those who choose to participate.
Precisely.
But how has this whole accreditation process changed? I mean, it can't be the same as it was, say, 20 years ago.
No, definitely not. What's really interesting, I think, is the increasing role of data and transparency.
Ah,
Today's accreditation programs, they heavily use comparative performance metrics. Basically, they benchmark how different organizations stack up against each other on key quality measures.
so you can see how one hospital compares to another.
Exactly. And often these results are actually made public. This push for transparency is meant to help patients, make more informed choices about where they get care.
Yeah, that feels like a pretty significant step towards holding the system more accountable.
It absolutely is.
Yeah.
And more recently, especially as we look at healthcare now, in 2025, accreditation has really had to adapt. Think about digital health,
Oh, right. Telehealth,
Mhm.
EHRs.
all of it. So now they're evaluating things like an organization's cybersecurity readiness,
Yeah.
the standards they have for telehealth services, how well their different electronic health record systems talk to each other, that's interoperability, and it's crucial.
Okay.
And beyond just the tech stuff, there's also a much stronger emphasis now on patient-centered care, really making sure the care revolves around the patient's needs and actively addressing health equity, making sure care is fair for everyone. Even things like environmental sustainability in healthcare practices are starting to come into focus.
Wow, okay. So accreditation is this evolving voluntary layer of quality assurance. Now, let's switch gears a bit and talk about the rules that everyone has to follow, the federal regulations. That sounds like the real foundation.
You've hit on a really vital distinction there. Accreditation is a choice, right?
Yeah.
But the federal regulatory framework that's set mainly by Congress and then put into action by the Department of Health and Human Services, or HHS, through
CMS, right. Centers for Medicare and Medicaid Services.
Exactly. That's the mandatory foundation, the baseline for healthcare quality. And you might remember, before 2001, CMS was actually called HCFA, the Healthcare Financing Administration.
Right, I remember HCFA.
Yeah,
So CMS, it sounds like a huge operation. What exactly falls under their umbrella?
it is massive. Fundamentally, CMS oversees the big federal healthcare programs, Medicare, Medicaid, and also CHIP, the Children's Health Insurance Program.
Okay.
Internally, they're broken down into different centers. There's the Center for Medicare Management, which handles the traditional fee-for-service Medicare.
Right.
Then the Center for Beneficiary Choices, that's all about educating people on Medicare and managing the Medicare Advantage plans, the private insurance options. And finally, the Center for Medicaid and State Operations. They oversee how the individual states run their Medicaid and CHIP programs, making sure they follow the federal rules.
Okay, that breakdown helps make sense of it. Now, you mentioned these things called conditions of participation and conditions for coverage. Those sound important.
They're absolutely fundamental. Think of them as the mandatory health and safety standards. Any healthcare organization's hospital, nursing home, home health agency, they must meet these standards if they want to participate in Medicare and Medicaid.
Participate, meaning get paid by them.
Exactly. If they want to serve patients covered by these federal programs and get reimbursed. These conditions are actually written into federal law. If you ever feel like some light reading, the hospital ones are in Title 42 of the Code of Federal Regulations, Part 482.
Okay, maybe later.
Yeah, right. But the key thing is, no meeting the conditions, no Medicare or Medicaid funding. Simple as that.
So failing to meet them is a huge financial blow. That creates a very strong incentive to comply, doesn't it?
Absolutely. And this is where we see an interesting link back to accreditation through something called the deeming process.
Deeming.
Yeah. CMS can actually recognize certain accrediting organizations like the Joint Commission we mentioned earlier if their standards are judged to meet or even exceed the federal requirements, those conditions of participation.
Ah, so if a hospital gets accredited by one of these deemed organizations,
Then CMS generally considers that hospital to have met the federal conditions too. It's like CMS saying, look, if you meet their tough standards, you've probably met ours as well. It saves duplication of effort.
that's actually pretty clever, leveraging the expertise of those voluntary groups. Now, you also mentioned a big shift towards value-based care within CMS. What does that mean, practically speaking?
This is a really important evolution in how healthcare gets paid for. Historically, it was mostly fee-for-service, right? The more stuff a provider did, more tests, more procedures, the more they got paid.
Right. Volume over value, essentially.
Exactly. Value-based care tries to flip that. It's about rewarding providers for the quality of care they deliver and the health outcomes their patients achieve, not just the sheer volume of services.
Okay, how do they do that?
CMS has been pushing this hard through initiatives like the Quality Payment Program, or QPP.
Yeah.
That came out of the Metal legislation back in 2015.
Yeah, right.
These programs increasingly use sophisticated data analysis, even AI now, to track patient outcomes and give financial incentives to providers who deliver better, more efficient care. The core takeaway is that healthcare payment is shifting from volume to value, from paying for quantity to paying for quality and results.
So the focus is shifting from just treating sickness to actually promoting health and wellness more broadly. That sounds like a much more sensible goal.
It certainly aims to be.
Okay, let's dig into those huge federal programs then, Medicare and Medicaid. Medicare came first, right? Or at the same time?
Both were actually established in the same year, 1965, as part of the Social Security Act. Medicare is the federal health insurance program,
Okay.
primarily for people 65 and older, but also for some younger folks with disabilities or those with end-stage renal disease, ESRD.
And how's it funded?
It's mainly funded through payroll taxes. That's why most people don't pay a monthly premium for Part A.
Part A, that's the hospital insurance part.
Correct. Part A covers inpatient hospital stays, care in skilled nursing facilities, hospice care, and some types of home health care.
Okay, and then there's parts B, C, and D. Quick overview.
Sure. Part B covers outpatient care. Think doctor's visits, medical equipment, preventive services. This one usually does have a monthly premium.
Got it.
Part C is Medicare Advantage. This lets beneficiaries choose to get their Medicare benefits through private insurance plans instead of the original government-run program. These plans often bundle parts A, B, and sometimes D, and might offer extra perks like vision or dental.
Okay, the private option.
Right. And finally, Part D provides coverage for prescription drugs. This is also delivered through private insurance companies, and most people pay premiums and deductibles for this too.
Okay, that clarifies the different parts. Now, you mentioned QIOs earlier, quality improvement organizations. What role do they play specifically for Medicare?
Right, QIOs. These are organizations that CMS contracts with specifically to monitor and work on improving the quality of care that Medicare beneficiaries receive.
So they're like watchdogs, but also helpers?
Kind of, yeah. The program has evolved. There was a big restructuring back in 2014, which created two main types.
Okay.
You have the Beneficiary and Family-Centered Care QIOs, or BFCC QIOs. They mostly handle patient complaints and do medical reviews if there are concerns about care quality.
Reactive, then.
Largely, yes. Then you have the Quality Innovation Network QIOs, or QIN QIOs. They're more focused on proactive quality improvement work, providing education, data, and support to providers and organizations to help them improve care system-wide.
Okay, proactive. And what are they focused on now?
What's really interesting now in 2025 is how much they're using big data and predictive analytics.
Ah, like we talked about with value-based care.
Exactly. They're using data to pinpoint areas where healthcare disparities exist, for example,
Mm.
or to develop targeted strategies to cut down on things like preventable hospital readmissions. It's about using data intelligence to drive real improvements.
That sounds much more targeted than just general quality checks.
Yeah.
Okay, let's switch over to Medicaid. Also started in 65, but you said it works pretty differently.
Very differently. Medicaid is a joint federal-state assistance program, not purely federal insurance like Medicare.
Assistance, okay.
It provides health coverage to a wide range of low-income folks, kids, pregnant women, seniors, people with disabilities. The federal government chips in a big chunk of the funding, around 60% on average.
But the states run the show.
Pretty much. Individual states manage their own Medicaid programs day to day, but they have to follow federal guidelines set by CMS.
So does that mean who's eligible can vary a lot depending on where you live?
Exactly. There are federal minimum standards, but states have flexibility. A key benchmark is the federal poverty level, the FPL. Many states cover people up to a certain percentage of the FPL, often around 138% now for certain groups.
And the ACA changed Medicaid eligibility too, right?
Hugely. The Patient Protection and Affordable Care Act in 2010 allowed states to expand Medicaid eligibility significantly, primarily to low-income adults who didn't qualify before. As of 2025, 42 states have adopted this expansion.
But not all states.
No, not all. In the states that did expand, it's led to much broader coverage for essential benefits like mental health care, maternity care, managing chronic diseases.
But it's still debated.
Oh, definitely. The financial implications for states, the role of the federal government, it's an ongoing political discussion for sure.
It seems like it. And just like Medicare, Medicaid is seeing innovation too.
Absolutely. A big trend is states moving towards managed care models. They contract with private health plans to manage the care for their Medicaid beneficiaries, hoping for better coordination and cost control.
Right.
States can also get federal waivers to try out new things, like different value-based payment approaches. And again, AI is starting to creep in, helping streamline the complex enrollment process, or even detecting potential fraud.
It's amazing how technology is weaving its way into these foundational programs. Okay, let's talk about payment again. The prospective payment system, PPS. That sounds really key for how hospitals get paid.
It's absolutely a cornerstone, especially for hospital financing under Medicare. It was introduced way back in 1983 with amendments to the Social Security Act,
Okay.
and it was a fundamental shift. Before PPS, Medicare basically paid hospitals based on their reported costs for treating each patient.
The more it costs, the more they got paid.
Essentially, yes.
Huh.
PPS changed that completely for inpatient services. It set up a system of fixed payments based on diagnosis-related groups, or DRGs.
DRGs. Okay, so how does that work?
Think of it like this. A patient comes in with pneumonia. That falls into a specific DRG. The hospital gets a predetermined fixed payment amount for treating that patient with that DRG, regardless of what it actually costs the hospital to treat that specific person.
Ah, so if they treat the patient efficiently for less than the DRG payment, they keep the difference?
Exactly. And if it costs more, they might lose money on that case. It created a powerful incentive for hospitals to manage resources efficiently and control costs.
So it really pushed hospitals away from that old fee-for-service model towards standardization.
Precisely for inpatient care, initially. And since then, the PPS framework has been expanded. It's now used in various forms for other settings, too. Home health agencies, hospices, skilled nursing facilities.
Trying to bring that cost control across the board.
Right. Promoting predictability and trying to rein in overall healthcare spending.
And how is PPS keeping up now in 2025? Especially with this focus on quality we keep talking about.
Well, It's getting more sophisticated.
Mhm.
We're seeing the incorporation of complex risk adjustment models.
Risk adjustment.
Yeah, using machine learning and AI to analyze patient factors, comorbidities, age, socioeconomic status, things like that, to better predict potential outcomes and resource needs. This allows for payment adjustments that reflect how sick or complex a patient actually is.
So it's not just a flat rate for everyone with the same diagnosis anymore?
It's becoming much more nuanced to account for patient complexity. And beyond that, you have programs like CMS's Hospital Value-Based Purchasing, the VBP program.
EBP.
That directly ties a portion of a hospital's Medicare payments to how well they perform on specific quality metrics, things like patient satisfaction scores, rates of hospital-acquired infections, mortality rates.
So payment is literally linked to quality outcomes now.
Increasingly so. It's a clear example of trying to drive improvements by hitting hospitals where it often matters most, their bottom line. It's moving away from just paying for activity towards paying for results.
Okay, it really feels like that value-based concept is threading through everything. Now let's circle back to those QIOs, the quality improvement organizations. Their role seems pretty broad. Can you trace their evolution a bit?
Sure, they have quite a history. It started back in 1972 with something called Professional Standards Review Organizations, or PSROs. Their main job initially was just ensuring care paid for by Medicare, and Medicaid was medically necessary and met basic professional standards, sort of a utilization review focus.
Okay.
Then, in 1982, the law known as TEFRA changed them into peer review organizations, or PROs. At this point, cost containment became a much bigger objective alongside quality review.
Ah, the cost focus creeping in.
Right. The name officially changed to Quality Improvement Organizations, QIOs, in 2002. And that name change reflected a real shift in focus towards proactively improving the quality of care.
Not just reviewing it.
Exactly.
Yeah.
This lined up with HHS's National Quality Strategy and the idea of the triple aim:
The triple aim.
better patient experience, better population health, and lower per capita costs. So QIOs went from basic oversight to cost control to really driving quality improvement. It's been quite a journey.
Definitely a big expansion of their mission. And you mentioned that key restructuring in 2014.
Yes, that was really important to split them into those two types: the BFCC QIOs, handling beneficiary complaints and case reviews,
For reactive ones.
and the QIN QIOs, the Quality Innovation Networks, focus more strategically on driving improvement initiatives, education, technical help for providers.
The proactive ones.
Right. As of 2025, there are 14 QIN QIOs and just 2 BFCC QIO contractors covering different regions across the country. And they are heavily reliant on data-driven approaches, now working on reducing healthcare-associated infections, improving care coordination between settings, things like that.
And they operate under a specific plan, right? A scope of work.
Exactly. They work under multi-year contracts with CMS, defined by a scope of work. The current one is the 12th scope of work, running from 2024 to 2029.
And what's the focus there?
It really doubles down on that triple aim. Key goals include creating healthier communities, trying to reduce disparities in cardiac care, diabetes management, boosting immunization rates, often using health IT to help.
Okay.
Making care safer is another big one, minimizing infections, improving those transitions between hospital and home, for example.
Right. Those transitions can be risky.
Very. And finally, promoting cost efficiency by supporting value-based care models and giving physicians feedback on their performance compared to peers.
Sounds like they're tackling some really critical systemic issues. Now, you mentioned something earlier about the data QIOs collect. It's not public, not subject to FOIA.
Yes, that's a really important point. Generally, the data that QIOs collect and use for their quality improvement work is protected from public disclosure under the Freedom of Information Act.
Why is that?
It's designed deliberately to encourage open and honest participation from providers. If hospitals and doctors knew all their quality data, including mistakes or near misses, could be made public or used against them in lawsuits, they might be much less willing to share it or participate in improvement efforts.
Ah, so confidentiality fosters a safer space for learning and fixing problems.
Exactly. It's meant to promote a culture of improvement, not punishment.
That makes sense.
Yeah.
Okay, let's shift to some landmark laws that have really shaped modern healthcare. The American Recovery and Reinvestment Act of 2009, ARRA. What was key there for healthcare?
ARRA was huge, passed during the economic downturn. But buried inside it was the Health Information Technology for Economic and Clinical Health Act. Everyone calls it the ITECH Act.
High tech. Right, I've heard of that.
iTech dedicated a massive amount of funding, over $22 billion, specifically to get doctors and hospitals to adopt and meaningfully use electronic health records, EHRs.
Meaningful use.
Yeah, it wasn't just about having an EHR. It was about using it for specific things like e-prescribing, tracking quality measures, sharing data. There were Medicare and Medicaid incentive payments for providers who did this, and eventually penalties for those who didn't.
So it was a big carrot and stick approach to digitize healthcare record.
Absolutely. The core idea was to drag healthcare into the digital age, improve efficiency, and potentially improve quality through better data.
And did it work? What's the adoption like now?
Oh, it had a dramatic impact.
Okay.
By 2025, adoption is really high. Over 95% of hospitals, more than 80% of eligible doctors and other professionals are using EHRs now. But the work didn't stop with just adoption. More recently, the focus has shifted to enhancing interoperability.
Making the different systems talk to each other.
Exactly. Making sure that patient information can flow securely and smoothly between different doctors, hospitals, labs. The 21st Century Cures Act in 2016 pushed this further. It mandated standardized APIs, basically, tech tools, to give patients easier access to their own data.
APIs, right.
And it also put penalties in place for information blocking, deliberately making it hard to share electronic health info.
So it's moved beyond just getting the tech in place to making sure it actually connects and benefits patients and providers.
That's the goal. Still ongoing work, but much progress.
Okay. Another huge one. The Patient Protection and Affordable Care Act of 2010, the ACA.
Yeah, the ACA. Truly transformative legislation. Its main goals were really broad. Expand health insurance coverage, improve healthcare quality, and try to control rising healthcare costs.
And it had a ton of different provisions, right?
Yeah. Oh, absolutely. Some of the biggest ones. Stopping insurance companies from denying coverage or charging more based on pre-existing conditions.
That was huge.
Huge. Eliminating lifetime caps on insurance benefits. Requiring coverage for certain preventive services with no cost sharing. Letting young adults stay on their parents' plans until age 26.
Right.
And it created the health insurance marketplace, the exchanges, where individuals and small businesses could shop for subsidized health plans. The whole idea was making coverage more accessible and affordable.
And it also led to ACOs, accountable care organizations.
Yes, the ACA was key in promoting ACOs. These are groups of doctors, hospitals, other providers who agree to work together to provide coordinated, high-quality care, especially to Medicare patients.
Coordinated care, trying to avoid duplication and improve outcomes.
Exactly. The idea is if they manage the patient's overall health well, keep them out of the hospital, avoid unnecessary tests, they can deliver care more efficiently and save money. The Medicare Shared Savings Program is the main vehicle for this. ACOs that meet quality targets and save money compared to benchmarks get to share in those savings.
And have they been successful? Are there many ACOs now?
They've grown significantly.
Mm-hmm.
As of 2025, there are over 600 ACOs participating in Medicare programs, covering around 11 million beneficiaries. And they did report significant savings, something like $2.1 billion in shared savings in 2024 alone.
Wow.
And of course, the ACA also included that Medicaid expansion we talked about earlier. Still a major factor in coverage rates and still, as we said, politically debated.
Definitely a law with a complex and far-reaching legacy. Okay, let's shift focus now specifically to legal protections for patients. You mentioned the Patient Self-Determination Act of 1990. What's that about?
The PSTA is all about patient autonomy, empowering patients in their own medical decisions.
Oh.
It requires healthcare providers, like hospitals and nursing homes, to inform patients about their right to make decisions about their care, including the right to refuse treatment.
The right to refuse.
Yes, and also their right to create advanced directives.
Like living wills.
Exactly. Living wills, durable powers of attorney for healthcare. Documents that spell out their wishes for medical treatment if they become unable to speak for themselves later on.
And providers have to ask about these.
They have to inform patients of their rights, ask if they have an advance directive, document it in their record if they do, and importantly, they cannot condition care based on whether or not someone has an advance directive. And now, in 2025, we're seeing more digital platforms emerge to integrate these advance directives right into the EHR.
Making them easier to find when needed.
Hopefully, yes. Making sure patient wishes are known and respected.
That's a really important protection for patient autonomy. Okay, another critical one for patients. HIPOA, the Health Insurance Portability and Accountability Act of 1996. Most people think privacy, right?
Yes. HIPAA is probably best known for its privacy rule. which sets national standards for protecting individuals' medical records and other identifiable health information, what they call protected health information, or PHI.
PHI, right?
But high pay also included the security rule, which sets standards specifically for protecting electronic PHI, ePHI. And the administrative simplification parts aim to standardize electronic healthcare transactions, like billing.
So privacy, security, and some standardization.
Exactly.
Yeah.
And the Pay Omnibus rule in 2013 really strengthened things. It made business associates think billing companies, IT vendors who handle patient data directly liable for high pay compliance.
Ah, extending the responsibility.
Yes, and it significantly increased the potential penalties for data breaches. The core principle is ensuring patient health information stays confidential and secure.
Which must be a huge challenge now with cyber threats.
Absolutely. In 2025, high pay compliance is heavily focused on cybersecurity. HHS and CMS issue constant guidance on things like ransomware prevention, securing data in the cloud. And we're even seeing AI tools being developed and used now to monitor systems for unauthorized access attempts, trying to catch breaches before they happen or limit the damage. It's an ongoing battle.
It definitely sounds like it. Keeping that sensitive data safe is paramount. And finally, under patient protection, you mentioned the Americans with Disabilities Act, the ADA from 1990. How does that apply to healthcare?
The ADA is a broad civil rights law prohibiting discrimination based on disability. In healthcare, this means facilities must be physically accessible ramps, accessible restrooms, exam rooms, etc.
Physical access.
Yes, and providing reasonable accommodations, things like sign language interpreters for deaf patients, materials in large print for visually impaired patients. The 2010 ADA standards for accessible design lay out the specific requirements for physical accessibility.
Okay.
And more recently, with the rise of telehealth, there's been a big focus on ensuring those digital platforms are accessible too. Making sure they work with screen readers for blind users, providing captioning for deaf or hard of hearing users, using other assistive technologies. It's about ensuring everyone has equal access to care, regardless of how it's delivered.
That's vital. Ensuring accessibility keeps pace with technology. Okay, now let's turn to laws that primarily impact the healthcare organizations themselves. Corporate compliance seems essential.
Oh, absolutely critical. With this incredibly complex web of federal and state regulations, the risk of penalties for noncompliance is huge for healthcare organizations.
Lawsuits.
Exactly. The Office of Inspector General, the OIG at HHS, provides a lot of guidance on what an effective corporate compliance program should look like. They outline 7 key elements.
7 elements, okay.
Yeah. Things like having written policies and procedures, having a designated compliance officer with real authority,
Right.
conducting effective training and education for all staff, doing internal monitoring and auditing to find problems, having clear lines of communication for reporting issues without fear of retaliation.
Like a hotline.
Often, yes. Enforcing standards through well-publicized disciplinary guidelines and responding promptly to detected offenses and taking corrective action. The whole idea is to build a culture where compliance is expected and supported.
It sounds very structured, very proactive.
It needs to be. There was even a resource guide back in 2017 from the HCCA and OIG suggesting metrics organizations could use, like how often they audit, training completion rates.
Measuring effectiveness.
Right. And there are also self-disclosure protocols. If an organization finds a problem itself and reports it, the penalties might be lower than if the government finds it first. And again, AI is starting to play a role here too. Tools to analyze billing data for anomalies, monitor adherence to regulations automatically.
Using tech to stay compliant. Okay, another big one for organizations. The False Claims Act. This sounds serious.
Very serious. The FCA imposes major financial penalties on individuals or organizations who knowingly submits or causes someone else to submit false or fraudulent claims for payment to the government.
Knowingly. That's key.
Yes, it generally requires knowledge, which can include deliberate ignorance or reckless disregard for the truth. The penalties are steep as of 2025. The fines can be over $13,500 up to maybe $27,000 per false claim, plus potentially triple the amount the government was defrauded.
Yeah.
And those dollar amounts go up with inflation.
Per claim. Wow.
Yeah. And the FCA also has those famous quid tam or whistleblower provisions.
Right, where an insider can sue on behalf of the government.
Exactly. And if the government recovers money, the whistleblower can get a share, often 15 to 30%. It's a powerful incentive to report fraud.
And what kind of fraud does it cover?
All sorts. Billing for services not rendered, billing for medically unnecessary services, upcoding billing for a more expensive service than was actually provided, unbundling services that should be billed together. Recent enforcement is focused a lot on telehealth fraud, improper coding in electronic health records. It adapts as healthcare evolves.
So constant vigilance is needed. Okay, you also mentioned the Stark Law and the anti-kickback statute, preventing improper financial relationships.
Precisely. They both aim to prevent medical decisions from being tainted by financial incentives, ensuring they're based on patient needs, not potential profit.
Okay, how do they differ?
The Stark Law is more specific. It prohibits physicians from referring Medicare or Medicaid patients for certain designated health services, like lab tests, imaging, physical therapy, to entities where the physician or an immediate family member has a financial interest, ownership, compensation arrangement, unless a specific exception applies.
Exceptions are key there.
Very key. The Stark-Thur regulations from 2007 clarified many of these exceptions for common, legitimate arrangements. Stark is generally a civil statute focused on improper referrals.
Okay, and anti-kickback.
The anti-kickback statute is broader, and it's a criminal law. It prohibits knowingly and willfully offering, paying, soliciting, or receiving anything of value remuneration to induce or reward referrals of items or services payable by federal health care programs.
Anything of value, that sounds really broad.
It is. It could be cash, excessive rent, consulting fees, gifts. But like Stark, there are statutory exceptions and regulatory safe harbors that protect certain arrangements known to be low risk, like payments to bona fide employees, certain discounts, payments under personal service agreements that meet specific criteria.
So complex rules to navigate.
Extremely complex.
Wow.
And CMS regularly issues guidance. In 2025, for instance, there's updated guidance clarifying how these laws apply to telehealth arrangements, trying to allow innovation while still preventing kickbacks or self-referrals that could harm patients or the programs.
A very tricky balance. Okay, let's talk about the National Practitioner Data Bank, the NPDB. What is that used for?
The NPDB is essentially a confidential information clearinghouse. It was created by the Healthcare Quality Improvement Act of 1986 and later merged with another database in 2013.
Okay, what kind of info does it contain?
It collects reports on medical malpractice payments made on behalf of physicians and other licensed practitioners. It also collects reports of adverse licensure actions, suspensions, revocations by state licensing boards, adverse actions related to clinical privileges taken by hospitals, and certain other negative actions or findings.
And who uses this information?
Its main purpose is to support credentialing and licensing decisions. Hospitals, health plans, state licensing boards, other healthcare entities are required to query the NPDB when physicians apply for privileges or licenses, and periodically after that to see if there are any red flags in their history.
So it's a tool to prevent practitioners with potentially problematic histories from moving state to state without anyone knowing.
That's a key goal, yes. Promoting patient safety by improving the quality of information available during credentialing. And recent enhancements as of 2025 aim for more real-time updates on adverse actions, making the data even more current.
A vital background check tool, basically. Okay, nearly there. Clinical Laboratory Improvement Amendments, CLIA from 1988. Labs, right?
Yes. CLIA sets the quality standards for virtually all clinical laboratory testing performed on humans in the U.S., regardless of where the test is performed. Hospital lab, doctor's office, public health lab.
All labs.
Pretty much all of them. It requires labs to be certified by the federal government, meet specific requirements for personnel qualifications, quality control, proficiency testing.
Proficiency testing. Like, they have to prove their tests are accurate.
Exactly. Labs have to regularly test unknown samples sent by proficiency testing programs and get the results right to maintain their certification. Oversight involves CMS, the CDC, and the FDA working together. The Test Act in 2012 made some tweaks to the proficiency testing rules.
And how is CLIA evolving?
It's adapting to new technologies. In 2025, there's a lot of focus on standards for point-of-care testing, those rapid tests done right near the patient, maybe in an ER or clinic.
Okay.
And also for the complex testing involved in things like genomic sequencing, which is becoming much more common in clinical care for personalized medicine, ensuring quality and reliability as the technology advances.
Makes sense. Okay, Safe Medical Device Act, SMDA 1990. About devices, obviously.
Right. SMDA focuses on the safety of medical devices after they are on the market. It requires manufacturers and user facilities like hospitals and nursing homes to report to the FDA if they become aware that a device may have caused or contributed to a death or serious injury.
Mandatory reporting of bad outcomes linked to devices.
Yes, typically within 10 days. It also requires manufacturers to conduct post-market surveillance on certain permanently implanted devices. The goal is to quickly identify and correct problems with devices already in use.
And has that evolved too?
Yes, the FDA Safety and Innovation Act, FDA, in 2012 strengthened FDA's post-market surveillance capabilities and also aimed to streamline the approval process for some innovative devices. And now, in 2025, with the rise of software as a medical device and AI-driven diagnostics,
Great, AI again.
the FDA's Digital Health Center of Excellence is playing a huge role in developing frameworks and monitoring the safety and effectiveness of these new kinds of digital health tools that function as medical devices.
So the definition of device itself is expanding.
Absolutely.
Okay, last one. Occupational Safety and Health Act, OSHA 1970. This is about protecting the workers.
Exactly. OSHA's mission is to ensure safe and healthful working conditions for employees across all industries, and healthcare is definitely included.
How does it apply specifically in healthcare?
Well, there's the General Duty Clause, which requires all employers to provide a workplace free from recognized hazards that could cause death or serious harm.
Okay.
In healthcare, OSHA has specific standards too, like the bloodborne pathogen standard to protect workers from needle sticks and exposure to infectious materials. Workplace violence prevention is also a major focus in healthcare settings. Those are among the most common citations OSHA issues in healthcare.
And what are the current focuses for OSHA in healthcare?
In 2025, there's a lot of emphasis on preventing ergonomic injuries, back injuries, brains, strains, which are incredibly common due to lifting and moving patients.
Exactly.
And also, particularly following the pandemic, there's a growing focus on supporting the mental health and well-being of healthcare workers, addressing burnout, stress, and providing better support systems. It's a reminder that the regulatory system has to protect the caregivers too.
Wow. Okay. We have covered an absolutely enormous amount of ground in this deep dive. It really, really hammers home how interconnected all these pieces are. The regulations, the accreditation in shaping the quality, the safety, just the overall function of the healthcare system we all depend on.
It really does. And you can see these major themes running through it, can't you? This continuous push towards value-based care.
Right. Paying for outcomes.
The huge integration of digital health, AI, telehealth into everything,
Everywhere now.
and this really important growing emphasis on protecting patient rights and, crucially, safeguarding their health data.
And it's so clear, as you've laid it out, that this isn't static. It's constantly changing. With AI advancing so fast, telehealth expanding, as of May 2025, this whole landscape is just continuing to evolve incredibly rapidly.
Which brings us, I think, to a really important point for you, the listener, to maybe think about. Considering this whole complex framework we've just walked through, how does understanding these rules, these accreditation standards, actually empower you as a patient? And how might these big forces, value-based care, digital health, data privacy, influence the future of a care you receive, or how it's delivered? Maybe just take a moment later to think about one specific thing we discussed.
Yeah.
Maybe it's the security of your own health records, or this shift towards paying doctors based on keeping you healthy. How might that actually affect you, or maybe someone you know, in the coming years?
That's a really powerful thought to end on. It definitely brings it home. Understanding this stuff, even though it's complex, isn't just for the experts or the administrators. It's relevant for all of us.
Absolutely.
We really hope this deep dive has helped clarify some of these vital aspects of healthcare, and we encourage you to keep exploring, keep learning about the forces that shape the care you receive.